Good evening, everyone, and welcome to tonight's webinar, COVID-19 and Influenza Update. Before we commence tonight's webinar, I'd like to acknowledge the traditional owners of the respective lands upon which we are meeting and pay my respects to elders past, present and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Island people we may have joining us. I will now pass over to Tim and Ramya to commence tonight's webinar. Thank you.
Thank you, Lou. Hello and a warm welcome to everyone in the audience tonight. We've almost got 400 attendees on board and we're looking forward to a discussion today on a number of topics. Welcome, Ramya.
Thanks, Tim.
Look, tonight's topic actually started as being an update on influenza and immunisation, but given the environment, we've changed it to include some updated information around COVID-19. So the ways tonight's presentation will work will be we'll do an update on COVID-19 and then talk about the rollout of the influenza immunisation program and influenza in Western Australia and Australia, and then we'll take audience questions. I would say, because there are 400 attendees, just a word of warning that we definitely won't be able to get to everyone's questions, and we'll do our best to answer some of the questions that come in, but please bear with us. So with that in mind, we might welcome Paul. Welcome, Paul, tonight.
Hey, thanks for having me.
Do you want to go ahead with your presentation now, Paul?
Yeah, absolutely. We'll start out with overview of the epidemiology and some of the recent developments of COVID-19 in Western Australia, and Australia generally. And then we'll move to talk about what is a very important subject, particularly this year, is influenza and influenza vaccinations. So I'm doing this from home tonight because, as luck would have it, yesterday I was notified that I'm a close contact to a confirmed COVID case. Spent 17 hours with them and sitting in the same row on a flight from Dallas to Sydney last week. So we'll be doing it from home, and I'll need to say advance the slide or next slide to proceed. So next slide. So with COVID, we'll talk about the epidemiology, the testing recommendations that are currently in place, and some aspects of control that you've obviously heard about through the media and other sources. Next slide, please. So if we look at cases in China, as we all know, this is where it was first identified, the COVID outbreak. You'll see that they had a dramatic peak in February and have had declining cases since then. And I think this is worth noting. While there are some people that have questioned the data coming out of China, Dr. Dale Fisher is an Australian ID doc that works in Singapore, a friend of mine, and also a member of the Goran steering committee that I'm on. And he was on a mission to China for WHO to look at this, and he believes that this really is a fall in actual cases in China. So I think take that as a little bit of encouragement as we see what's going on in the rest of the world right now. Next slide, please. So it's reflected in the death rate coming down in China, or the number of deaths, I should say, coming down in China to somewhere between 3,000 and 4,000 now that have been determined. And this is in a country of 1.4 billion people. Again, those are encouraging signs, and hopefully will continue in the months to come. Next slide, please.
Paul, just to interrupt you there, that change in deaths and cases, are we seeing changes in the case death rate and the reproduction number?
Well, what we saw in Wuhan was a death rate that was somewhere around 3% of the cases, but outside of that in China was, I think it's the figure that's being put out as 0.9%. So a much lower death rate outside of that initial outbreak that spun out of control in Wuhan, and probably reflected overwhelming the capacity there. So again, some encouraging signs, and we can. That lower figure for deaths has been also reported in other settings in Asia, particularly South Korea. So go ahead, next slide, please. If we turn to outside China, what we see is sort of as you would know from the news, a rapidly escalating number of cases from the rest of the world. Next slide, please. The real growth in those infections outside of China have been, as you know, Iran and Italy particularly, but also some other countries. What I would, if you're looking at this slide, what I would note though is the Republic of Korea, which had a sizable number of cases early on, but has also seen a decrease in cases through very concerted efforts to identify cases and isolate them in quarantine contacts. Over. Next slide, please. So in Australia, we've seen we had a sporadic cases being introduced, and we've gradually seen an increase occurring across the country. These are the official figures as of today, about 350 across the country. Next slide, please. And this is from a different source of data, which takes items from news reports and therefore is in advance, I guess, of the official figures. But you can see this is a concerning trend as the cumulative number of cases in Australia begins to accelerate. It's not unexpected, but obviously it's a concern. Next slide, please. So where are these cases occurring? You can see the black line there is New South Wales. Not unexpected, large population, lots of major travel hub, and then you have Victoria and Queensland following suit, which makes sense. And there in that little blue dot at the bottom is Western Australia. So we are coming up as well, but so far not to the level seen over in the eastern states. Next slide, please. So I guess the most important thing is maybe not so much the number of cases, but where they're being acquired. And what we're seeing from this unofficial data, at least, is that there's 61 of the cases so far in Australia are believed to be related to local transmission. Most of that is being reported out of New South Wales. They tend to do a good job of reporting this information, or I should say a consistent and timely job, so that might reflect some of it. But I guess what this suggests is we're transitioning to a phase where it won't be necessarily from imported cases, but actual local spread is probably going to increase in the country, as we've seen in other jurisdictions around the world. Next slide, please. And that's reflected in this, which again is the cumulative cases. You see the imported ones in gray and the ones due to local transmission. You can see that that's starting to increase as time goes by. Again, not unexpected whatsoever, but just the reason that some of the measures that have been recommended by government are being brought forward at this time. Next slide, please. And this shows where these imported cases have been coming from up to now. And there's two things I would take away from this slide. One is you can see that the United States has now become the biggest source of imported cases to Australia. That's that sort of orange line shooting up there. And I think that reflects that the United States has a much bigger outbreak than their official numbers show. That's probably the result of basically delayed and very limited testing early on. And so there's a lot of cases there that have not been previously diagnosed, would be my guess. The other thing I would take away from this slide is you can see there's a wide variety of exposures for people that were diagnosed in Australia, in overseas countries. And this, I think, is the rationale for the recently imposed 14 days of mandatory quarantine for people arriving from anywhere overseas, because the exposures are occurring in so many settings around the world. Next slide, please.
Sorry, Paul, just to stop you. It does look rather positive, though, that you do see a very immediate sort of flatlining of growth as soon as you institute a travel ban, doesn't it?
Yeah, absolutely. Well, I guess if folks are coming back from a place, they can't introduce it. So yes, it's hard to do a complete travel ban, and certainly there will always be Australian citizens and permanent residents who need to come home, and that's going to occur. I think this whole importation, though, issue will become less important as the weeks go on, and we see that more and more transmission is related to local exposures. that may result ultimately at a time where the travel bans are unnecessary because they're not actually adding much to the control locally. Next slide, please. And this is the age group of the cases that have been identified. And as you can see, it's bell-shaped curve, classic, but would reflect a lot of younger adults and people out and about and travelers internationally, obviously. But I do want to emphasize we've had 5 deaths so far in Australia in these cases, and the age range for those deaths has been from 77 to 95 years of age. Next slide, please. So this is the data as of noon today in Western Australia. We've had 31 cases confirmed, and I believe all but 2 of those are related to international exposure, and the other 2 are close contacts of known cases. But it also shows that we've tested and ruled out infection in 6,582 individuals. So there's been a lot of testing that's been done in Western Australia to identify those 31 cases today, and that reflected the ability of our labs, particularly PathWest, to really step up and increase capacity for testing in the early days of this outbreak. And that's obviously very important because our initial strategy is to identify cases and isolate them and quarantine their contacts in an effort to prevent onward transmission. Next slide, please. But as you all might know, or you'll find out tonight, we've had to have some changes to that, the ability to test in Western Australia, and these have been put out in clinician alerts. As you can see, this is our 15th clinician alert since the outbreak started. These are all available online, and I urge you, if you're practicing in Western Australia and you want to know the latest, is to go to our website and click on the last clinician alert, and you'll know where we stand. This one was changed on the 13th, and then again on the 16th of March. So we will update them regularly as developments occur. But let's go through what those changes were that came about. Next slide, please. So what occurred essentially is we had extreme pressure for consumables required, reagents, and particularly to run the test. These reagents are produced overseas. The suppliers were not able to meet their obligations that they had agreed to, and essentially we were in danger of running out of the ability to test if we continued with the strategies we had prior to this. And so it required us to change to be more strict about who could be tested and where testing could occur. This wasn't done because we wanted to exclude GPs from having the ability to test, particularly in Metro, but simply because we were going to run out of reagents, and these reagents are actually used to test for other things besides COVID-19. So it's critical that we maintain some capacity, and that's why these changes occurred. Before I go on to talk about what the changes are, there is some recent information, some access to these reagents that potentially in the near future would allow us to readjust our testing strategy again. But at the current time, I'll present where we're at with our testing strategy in WA. Next slide, please.
Well, just to go back on that, one of the questions I had was whether that shortage of reagent will mean that we're less able to test for seasonal influenza when it comes on?
Potentially it would. Even I'm told measles PCR would need these reagents. So it's important that we conserve the ability to test at all times for different things. Like I said, just recent information from yesterday and even earlier this morning it gives us hope that supply chain is going to be freed up, and we might be able to go back to more more case finding efforts for COVID-19 whilst not risking running out of these reagents going forward. Essentially these reagents come from the United States, and the United States is using up a lot of them at the current time is my understanding. All right, next slide, please. Sure, please feel free to interrupt and ask questions as need be. So currently where we're at, who should be tested in Western Australia? People with fever or an acute respiratory infection, if they have a respiratory infection with or without fever, if they have proven international travel in the last 2 weeks. And by that we mean they should be able to demonstrate that they've actually traveled and not just a verbal report. And most people have some sort of itinerary or other thing to back up that claim. Proven close contact in 14 days with a confirmed case of COVID-19. So I guess if I become sick in the next week or so, I'm a proven contact to a COVID case on the plane. I would be able to be tested. Hospitalized persons with severe bilateral pneumonia, regardless of a travel history, can be tested. Obviously, we're looking for severe community-acquired cases potentially. And then next slide for the fourth criteria. Next slide, please. Any healthcare worker with direct patient contact who has a fever and acute respiratory illness, we would recommend testing. Obviously, we're looking for occult cases that might have occurred in the healthcare system. And our definition of healthcare worker for this includes workers in aged care, disability support workers, or anyone that's really working with vulnerable patient groups. Next slide, please. So testing right now in the metropolitan area is only to be done at the COVID clinics or hospital patients, if they are inpatients in a hospital. In a country areas, because COVID clinics are just being established, it can be done in hospitals and some other settings is listed there through the WA Country Health Service, Silver Chain, Aboriginal Medical Services, and Royal Flying Doctor Services. Next slide, please. So if you are tested for COVID, it's really important if you're advising patients that they need to remain isolated until the test results are available. We're all aware of the clinician over East who was tested and then continued to work. And then when the results came back positive, that caused quite a dilemma. So while your results are perking for sure, if you're not already in isolation because of foreign travel, or being a known contact to a case, you need to not be out in the community till we know those results. There's at
Just
this
another
point in
question.
time. Go ahead.
Sorry to interrupt. For relatives of and family members who cohabitate with people who are being isolated, do they need to stay sort of relatively isolated as well? And what effect does that sort of have on a household?
So contacts of contacts or people that have arrived from overseas do not need to be isolated. Obviously, they need to remain alert for symptoms, and if they would become ill, they shouldn't be out in the community like anyone with an illness. But if you're a contact to a confirmed case, yes, you do need to remain isolated. So if it's a confirmed case of COVID and you're a contact, you need to be in isolation until 14 days have passed. Okay.
Right.
Paul, can I just jump in there for 2 seconds? Sorry, I've had a few patients come in and ask me about the difference between quarantine and self-isolation. Could you just give us a quick brief on that?
Sure. Isolation is a word we typically use for people that are ill, and you're trying to prevent them from transmit to others. A quarantine is for people that are well. That's how the words are used. So they get misused a lot. It's not a big deal, but if we put somebody in quarantine, that's somebody who's not ill, but we don't want them out in the community because they may develop illness. And because we believe that you can transmit this new coronavirus at least a day before you develop symptoms, we're asking people who are known contacts of known confirmed cases not to be out in the community because just like measles or other things, they could be spreading it to others before they even become ill. And so we want to emphasize that there's no reason to test asymptomatic individuals. We've had a lot of folks that are just worried, wanting to come in for testing. We've also had requests for, employers saying, you've traveled overseas, I want you to go to get a clearance test before you can come back to work. That is not recommended. It's not appropriate for many reasons, but certainly we're not testing asymptomatic people at this time. Next slide, please. So for testing, we're also trying to conserve swabs, which are in short supply, not just reagents. So if you are doing these, and this would be for folks who are at the clinics or in a country areas, we're using a single swab. You swab the oral pharyngeal throat swab first, and then insert that swab into the nasal passages. If you have viral transport media, that's preferred. Because we think the recovery is slightly better, but not having viral transport media should not be an indication not to test because it will still work on a dry swab. And if you have flexible shafts, you can actually do proper nasal pharyngeal swabs on both sides and send those in as well. Next slide, please. This is obviously a notifiable disease. If you're aware of a COVID case, you should report it. We have an online reporting form, which is quite succinct and brief. That is the link for the REDCap reporting. You no longer need to call in each case by phone as it occurs, because we check the REDCap frequently and repeatedly. Next slide, please. I'd like to talk a little bit about the illness, though, and try and bring some context to what we're seeing around the world, and perhaps put a bit of balance with things. The majority of people who get COVID-19 do not have a serious illness. That was true even when the testing in China was limited to more severe cases, where they were saying 80% of their cases were not severe. And I was able to be on a call with South Korea CDC last week, and they were saying 60% of the individuals they tested and were positive in South Korea were actually asymptomatic. So there's certainly a lot of infection that's occurring that's asymptomatic or mildly symptomatic. So how I frame this up is that as an individual, on average, and this is leaving, unless you're elderly or have severe underlying medical condition, as an individual, you're probably going to do okay based on probabilities if you get COVID-19. The issue is, on a population level, we're still at risk of having many poor outcomes, because if a lot of people get this illness, even that small proportion that are at higher risk of having a poor outcome can potentially outstrip our existing capacity to treat. And that's really what we're trying to address here. Isn't that we think this illness is necessarily going to be serious or severe for most people that get it, just that we could get a lot of cases at once, and some of those people will be at risk of severe illness, and they could swamp our health system. Next slide, please. So we want to keep those with non-serious illness out of the hospitals and out of the hospital system, because we want to reserve that capacity to treat those people, to evaluate and treat those people who potentially really need it. We also want to, if we can, reduce the overall number of infections, obviously, and most importantly, we want to reduce the rate of new infections that we're having every day, every week, or whatever timeline you want to use, so that we can deal with the increased demand that is likely to occur if transmission becomes more widespread. Next slide, please. And so that is what you've heard talked about. In epidemiology, we've been talking about this with pandemic influenza for a long time, but what is known as flattening the curve. It's trying to delay the peak of the outbreak and also decrease the number of cases that might be presenting in any given time frame. And hopefully you decrease the overall number of cases, but what you're really trying to do is preserve your health system capacity to take care of those who desperately need it. Next slide, please. So with that in mind, that is where the Commonwealth government has decided to ask all travelers returning to Australia to stay in quarantine for 14 days. It's to limit those introductions and try to reduce the amount of onward transmission that could occur as we see these rather explosive outbreaks occurring in Europe and potentially the United States, and bringing many new cases in a short period of time to Australia, potentially, if quarantine was not imposed. There's also been a recommendation that gatherings over 500 people not go forward, and that's the same reason as they're trying to prevent explosive situations where there's transmission to a lot of people, as happened in South Korea with associated with that particular church, with widespread infection that occurred in those large gatherings. Next slide, please. So we call these non-pharmaceutical interventions, and the other term thrown around a lot is social distancing. And people understand those, but I was on a WHO conference call last night, and the behavioral scientists were saying, they really think we need to move away from social distancing, because what we're talking about is physical distancing and trying to get social cohesion, collaboration, commitment to these measures of basically restricting our activities in society for a while we try and protect the most vulnerable people in our society from poor outcomes. Next slide, please. So we really need persons who have an illness to self-isolate, right? We need to make that the new norm. We say it all the time, but we all know that we think our jobs are important, and other things where we continue to go to work or go out when we're ill. The new norm in this COVID-19 situation needs to be that we self-isolate when we become sick. We want people with mild illness to seek medical advice via the phone. There's now a ability for reimbursement for that for GPs for some sectors. We think that's fantastic, and we really want to drum up phone consultation for people that have mild illness. And then thirdly, people who are well need to reduce their potential exposures in the community. And by that, I mean, we need to make it the new norm where we actually adhere to the recommended 14 days of quarantine if you've traveled, or if you're the contact of a confirmed case, or just not going out in the community as much, to reduce our exposures and ultimately help contribute to flattening the curve for the cases as they occur. Next slide, please. So modifying individual behavior and our community norms is the key to reducing transmission in this. Governments won't be able to stop it. Doctors won't be able to stop it in and of themselves. Public health efforts to identify cases and isolate them won't be enough. We really need to change our community norms. But there needs to be a balance between the negative impacts of this, particularly the economic and societal disruption that will occur as we go forward. I take the long view that people's health status is probably the single biggest determinant is their socioeconomic status. And putting a lot of people out of work is certainly not going to be conducive to their health, both their mental health and their physical health. So really, as we try and flatten the curve, it's how to get the balance right between what we need to do to preserve hospital capacity with the minimizing economic and social disruption. So I think medical professionals like yourselves are key to promoting calm, constructive change and helping us to avoid panic as we go forward in this. Next slide, please.
Paul, I'm going to stop you there because we're about to move on to influenza. We've got a few questions, which I think we'll just give a couple of minutes to. One of the questions I was going to ask is, you mentioned before the idea of taking some isolation if you do have an upper respiratory illness. If COVID becomes the sort of the prevalent strain of illness out there, would the recommendation for isolation be similar to the COVID recommendations around isolation, or is it just the duration of the illness?
I think we'll see it be more the duration of the illness. I think we will see pretty quickly that we're not going to require testing for people to come out of isolation after they've been confirmed as a case even. And it'll be if you're recovered and you practice good hygiene, you can return to activities, right? And not necessarily be 14 days. I can't speak for what CDNA will say, but that seems to be a workable solution. And most of us believe that transmission occurs early in this illness, perhaps, some of it perhaps before you become ill, but particularly in the early stages of illness and not so much later after one has recovered.
So Paul, with regards to COVID, like if someone acquires COVID and they've been confirmed, does that actually mean that they get an immunity to it?
We don't know about this particular coronavirus, but you would assume so. and that's based on other coronaviruses. As we all know, there are I believe 7 types, but as we all know, they cause the common cold and they circulate widely. And it's believed from those coronaviruses that essentially you get a couple years of immunity after infection. So we would expect that to be true. With this, I have seen some WHO work that indicates that people are not getting reinfected in the areas where they've had outbreaks.
So that means after 14 days of quarantine, if they're positive for COVID, then they are back to normal and can resume life in the normal population, normal life?
Absolutely. And that's where I have a little bit of hope that if there's a tremendous amount of very mild illness or asymptomatic infection even, that it will impart immunity, and that will ultimately drive the, as a proportion of the population becomes immune, the transmission no longer occurs because there aren't susceptibles to hit. That will ultimately maybe play a big factor in us being able to get in front of this outbreak, is the immunity that's derived from mild and asymptomatic infections. Right. But there's still a lot we don't know that's based, as I said, on other coronaviruses that we know more about. But we presume based on first principles it would apply.
Paul, this is just with regards to the personal protective sort of equipment, with regards to the latest guidelines for testing, preserving this. What are the recommendations for GPs seeing patients with flu-like symptoms and using this equipment?
So if you're testing individuals you think you might have COVID, obviously we're using droplet precautions. And if you're doing a procedure that is likely to result in aerosol, or a severely ill patient who's likely producing aerosols based on their coughing situation, but perhaps higher level protection.
That's great. We might wind the questions up there and move on to the influenza discussion, Paul.
Yes, because I definitely want to talk about flu, because this is something we can do as a health system, as GPs, to actually help flatten the curve. It's in our hands. We do it all the time. This year, we just need to do it the best we've ever done it. So what I'll do is I'll talk about flu notifications from last year, vaccine coverage, and vaccine availability. And we'll go through this fairly quickly so there can be questions about the flu vaccination program if need be. Next slide, please. So as you know, last year we had a very rough flu season, particularly in WA, but it affected the whole country with lots of concern in the media and also increased case counts. Next slide, please. As you can see there from the blue bars, which is last year, it was a banner year pretty much across the country. In WA, that we were striking that we hadn't had a bad year in 2017 like other jurisdictions had experienced. So it really stuck out how severe last flu season was compared to the prior years here in Western Australia. Next slide, please. And this just exemplifies that. These are the number of notifications for confirmed flu that came into the health department. The two things there is both the number of notifications was much greater. In part, that was due to increased testing capacity in the state, but it was also due to a lot of flu circulation. The other very notable thing is it came extraordinarily early last year, and that was based on slightly increased levels throughout the warmer months as we went into flu season. Next slide, please. Last year was a H3N2 predominant season. They tend to be the heavier seasons we get, and that may explain some of the severity that we saw. Next slide, please. So as far as the number of notifications, who was getting influenza, it might surprise people to know that it was young children and children 5 to 9 years of age, and even 10 to 14 years of age, as far as numbers of diagnoses that were being sent to the WA Health. Next slide, please. But if we look at rates, obviously the number of children, if any particular year is more than the number of older individuals. So persons 85 plus had the highest rate overall. But again, you still see this pretty prominent peak in kids 9 years and under, or high rates in that age group. And the blue bars there reflect the higher rate in older Aboriginal individuals that occurs. And this is reflected in obviously our recommendations for vaccination, which we'll go through shortly. Next slide, please. So if we look at the different years, we have the hospitalization, number of cases and the hospitalizations that occurred. You can see that on average, around 20 to 23% of the notified cases are hospitalized, and about 0.6 to 0.8% die, or at least for the cases that get reported. This was lower in 2019, and that reflects the increase in testing that occurred. More mild cases were tested, and we saw a fall, actually, even though despite the larger numbers, a fall in the proportion that were hospitalized and the proportion that died. I would just note that, like for 2017, that 0.8% deaths is similar to what's being reported to COVID in places like South Korea at the current time and China outside Wuhan. So it sort of depends on how much testing you do, what your rates are going to be. Next slide, please. But if we look at not just testing, but actually people showing up with influenza-like illness, the rate for GP consultations, what we see is it was a heavy early year, but not dissimilar, completely dissimilar to 2016, which had been our last big year. It actually is higher. You can see from that area under the curve, but certainly I think that suggests that increased testing was really a contributor to the fourfold increase in notified cases or thereabouts that we saw last year. Next slide, please. So why do we vaccinate? Well, we know the vaccine isn't perfect, but people who were vaccinated were 68% less likely to visit their GP, and almost a little bit more than half is less likely to visit a hospital with influenza-like illness. So although the vaccine isn't perfect, you can see that if we do it widely, it's potential to flatten the curve on our healthcare system. Next slide, please. So how do we measure how we're doing for vaccinations? We have a national register for all ages now. The register is getting better at capturing flu vaccinations. Not all of them are captured, but we're still using this data as the system improves to track how we're going. And I'll present some of that now. Next slide, please. So if we look at vaccinations last year compared to the year prior, what we see is we had a dramatic increase. The media around flu, the number of cases that were being reported resulted in a major 33% increase in our under 5 vaccination rates, and our over 65s went up 14%. Again, this is data that's captured in air, so probably the real proportion that were vaccinated is higher, particularly for working age adults who might have gotten their vaccines at other places that don't report to air yet, and even for older adults. But really a great effort last year with the highest vaccination coverage we've ever had. As you can see, that in 2019, almost 800,000 people were vaccinated, nearly doubling our figure from the prior year. Next slide, please. If we look at vaccination by Aboriginality, fortunately, it is higher in Aboriginal persons, but we need to do an even better job because, as you saw, those rates, particularly in the older Aboriginal individuals, the rates of diagnosis are much higher. So although we're doing well and getting parity and even better than that, it would be great if we could do even better for our Aboriginal communities. Next slide, please. If we look at when people were vaccinated, the take home from this is that the 65s and overs, they come in early, and that's going to serve us well this year, I think. That's that aqua line going up with the vaccinations to older individuals. They tend to be ready to go, the 65s and over, and we want to use that to our advantage in this era of COVID. Next slide, please. So for other important populations, we just looking at the latter bars here, we now use the midwives notification to measure how well we're vaccinating pregnant women, and as you can see, that figure is coming up to 56% recorded in the midwives notification system, and the proportion that we don't know is going down. Again, I suspect if we had complete data, we'd be approaching 70% vaccination. Again, that's very good. Pregnant women are vulnerable, their children or newborns are vulnerable in flu season. So that's a good figure. We'd like to see it higher, and I'd ask all GPs to really make an effort in that regard. Next slide, please. So as you know, you can vaccinate pregnant women at any stage of pregnancy. It can be given with the pertussis vaccine. You can revaccinate women who've had it if they got it towards the end of last year with the previous year's formulation. You should revaccinate them. And if they were vaccinated before they become pregnant, they can be revaccinated during pregnancy, so they develop antibodies that can be passed to the infant once it's born. Next slide. So just briefly for at least our state healthcare workers, we had our coverage would indicate in our hospitals and other settings, we had 66% vaccination. It was by far our highest reported coverage that we've had. Of course, we want to do better. We want to make sure that healthcare workers this year and every year can stay on the job during winter respiratory season to take care of patients. Next slide, please.
Paul, do you think I could just jump in there and just ask you about the timing of the influenza vaccination for this year? What would be your advice?
Okay.
When should we start vaccinating?
Yeah, absolutely. So as I'll mention here, when we go into ordering, we expect to have open up ordering by next week and have Fluad vaccine, which is the vaccine for older adults, available first. That's just how the supply lines are going to come in. Given our issue with the potential for a dynamic outbreak of COVID in the coming months, I think it's important that we vaccinate early to try and make sure we don't overlap COVID and influenza at the same time. We want to protect those older individuals from influenza and make sure that that we've got them protected when flu season starts. So my advice would be, as soon as vaccine is available, you should start calling patients in to be vaccinated. It'll also prevent us from having a situation where there's a lot of respiratory illness in the community to treat while you're trying to get people through the vaccination, through the flu vaccination system. So I think we should go early this year. I'm a big proponent in prior years of trying to go closer to the peak of flu, but I think given the exceptional circumstances, we really want to try and avoid superimposing influenza visits, for illness visits with COVID illness in our communities. Next slide, please.
Just on that note there, should a booster be considered in about 3 or 4 months' time?
You could consider it for particularly high-risk patients. There's no contraindication against it. Unfortunately, there won't be a funded program to cover 2 doses for everyone that the National Immunization Program provides vaccine for. I'm jumping ahead here, but that's fine. We actually have more vaccine coming in this year than ever before. We have 100% of the number of doses we need to vaccinate kids under 5. We have 100% of the doses we need to vaccinate adults 65 and over. So we know we have enough for first doses. We won't get 100% vaccinated, so there will be some additional doses. And depending on what our season's doing, revaccination may be possible, but it's no longer possible to bring in more flu vaccine than is already arriving based on the timelines for production. So 2 doses won't be possible for every individual, but might be considered in those at highest risk.
Okay, thank you.
Next slide. Real briefly, I'm just going to use this to say that 3 of the 4 strains this year are different from last year's vaccine, adjusted. The great news is that all the vaccines that we're going to use in WA, in Australia this coming year, are quadrivalent. So we no longer have the issue, the dilemma of older folks getting an adjuvanted trivalent vaccine. They will get an adjuvanted quadrivalent vaccine, a quadrivalent like everyone else gets. Next slide, please. So we have 5 vaccine formulations in the National Immunization Program. There's no longer a need for a special pediatric formulation. 3 of these vaccines, the adult dose at 0.5 mils, can be given to children. It's registered for use down to 6 months of age, and we'll no longer be distributing pediatric formulations. The caveat to that is the Effler quad is still not registered for children under 5 years of age. That and the adjuvanted vaccine for older adults are the only ones that couldn't be given to young children. So we have an additional 168,000 doses being brought in this year compared to last, which is great news for us. Next slide, please. Briefly, I won't belabor this, but how I would approach this is that Fluad, the adjuvanted vaccine, is the preferred vaccine for 65s and overs, and it should really just be reserved for them. For 5 to 65s, you can give any of the other vaccines, with the exception, as I noted, the Effler quad should not be given to the youngest kids, but 3 other formulations should be given to them. So it should be relatively easy to manage in practice now that we're not distributing juniors. Next slide, please. The age groups have not changed. I should say the risk groups have not changed for who's eligible for NIP vaccines. Young kids, all Aboriginal Torres Strait Islander individuals over 6 months, pregnant women, people 65 and over, and people with chronic medical conditions. So there's been no change to that. We may see with state funds availability to other aged children, but we'll need to wait and see, and in the next week or two we might have an announcement if that's confirmed. Next slide, please. As far as ordering vaccine, it'll be through our regular online system. We expect ordering to start earlier this year than last year, and as soon as product becomes available, as I said, we expect this to open up next week. Ordering for Fluad particularly, because that's going to be the first things into our warehouse, and we will move it out as soon as it becomes available. Next slide, please. As you all know, you use the online system to order. We're going to still use our regular delivery schedules, and we really want people to plan their orders to use before their next 2-week, if you're in the metro area, your next 2-week delivery cycle, so that we can make sure everyone has vaccine to administer to patients at any given time. Next slide, please. So having said that, I just want to point out that last year we had reported to us nearly 60,000 doses that were wasted. That's going to happen with a vaccine that you can only use in a short period of time. That's about $500,000 worth of inventory. So again, it speaks to ordering, trying to really gauge your demand and adjust your orders to what you are using in your practice. Next slide, please. So my final thoughts for this evening's webinar is this year it's really critical that we protect our seniors from flu by vaccinating them directly, and also protect our children. But as you know, children are a big source of influenza for older adults, so getting high vaccination rates in young children should help protect our seniors indirectly. And obviously, because they are at greatest risk from poor outcomes from COVID-19, we want to make sure that they're not getting impacted by influenza, since we can prevent that. We anticipate having ample vaccine supplies in the NIP, more than last year, so we ought to be able to build on last year's record success in getting vaccination coverage in our state. And promoting flu vaccinations and providing them is a way that GPs can directly help flatten the curve of respiratory illnesses. There's other things we do, but this can have a direct impact on improving our situation in the pandemic. Next slide, please. And I want to close by saying the public, and I say rightfully so, looks to medical professionals to be the voice of reason on health issues, a wide variety of health issues. But in this pandemic, I think GPs really have a unique role in helping communities address the challenges posed by the pandemic, and in imparting balance and in leading by example. And I know we're up to the task. It's a big challenge for all of us, but the medical profession, we really need to rise and help encourage people to adhere to social distancing measures, and at the same time try and prevent unnecessary panic and poor mental health outcomes. Next slide, please. I think that was my final one, and it is. And I want to thank you all for your attention here tonight and your interest in helping us address the pandemic and keeping our population safe from influenza.
Paul, thank you for that. Just a couple more questions just to follow on with regard to flu specifically, and then there's always going to be a few more COVID questions tonight. My first question really relates to testing for influenza. Now, assuming that we go back to an environment where we have reagent to do influenza testing, would you like GPs to be testing more widely and freely with people presenting with flu-like illness?
I mean, if resources were, not constrained in any way, certainly you can test for flu. Patients would like to know it. It's helpful for clinicians, but many times it's not actually used. It's not actually useful for changing the treatment advice. So, from my standpoint, I don't think it's likely we're going to have actually unlimited reagents and swabs given the number of illnesses that might be there. And I would tend to reserve testing for individuals where I thought it was important for their clinical management and not so much just for information's sake.
And just to clarify, if you are testing in one of those higher risk patients, the testing material is the same as what we mentioned before in COVID. It's the swab, dry swab in the nasopharyngeal swab and the oropharyngeal swab.
Yes, and typically in the past there might be two different swabs that were used and then actually combined at the laboratory. But to save on the swabs, because they are also in limited supply, we're recommending using the same swab. But I haven't heard any changes to the flu recommendations that we would depart from that approach.
We've got another question around COVID and the flu. So obviously in the Northern Hemisphere, there's an influenza season going on. Are there cases of simultaneous infections, and does that worsen prognosis?
Yes, there are reports of simultaneous infections, not just with influenza, but other respiratory pathogens, viruses particularly. I don't think there's enough data out there on those to know for sure whether it's more detrimental. You'd have to think that it could be, again, another great reason for us to really hammer flu vaccinations to try and prevent as many of those co-infections as might occur. We're a bit at a disadvantage, the Northern Hemisphere is going into their summer, so the Southern Hemisphere is really going to be the first place where we face COVID and potentially flu transmission. So we need to err on the side of caution and prevent as much flu as we possibly can.
Paul, with regards to the demographics or in terms of the patient population that affects COVID, it seems to affect more elderly people, whereas the flu seems to have quite severe symptoms in children. So is there any sort of reasoning behind this?
Yeah, so that's a very important question we don't know the answer to, but I thank our lucky stars every day that children aren't more affected by COVID-19. I mean, it's a shocking observation in this outbreak that is essentially almost all adult that's going on. You'd have to think it's my guess would be it's due to one of two things. Either children are getting other coronavirus infections, snotty noses and other things that are in somehow giving them indirect protection, or it's actually the immune response in older adults. It's detrimental in some way. That would be my guess. Is I've tried to look and see if there's a difference in the number or proportion of receptors for this virus between adults and children. I can't find any evidence that that's the case, because that could be a third explanation. But I'm just really thankful that the impact has not been severe on children to date.
And look, our last question I think we might put in there, Paul, we've got quite a few questions from GPs about the role of ACE inhibitors and angiotensin receptor blockers in affecting the severity of COVID infection.
Yes, I've seen that report. I've also seen the European Respiratory Medicine Society saying it's far too early to recommend withdrawing treatment on the assumption that it might help in COVID infection. And that would be my position. I will defer to full-time respiratory doctors and ICU doctors to make that call. But this is basically one report. I don't think we should withdraw therapeutics that we know have benefit until we have more information that the risk is worth the benefits of withdrawing.
Fantastic. Paul, we've had almost 450 attendees on tonight, so it's a very large attendance. Everyone stayed on to the very end, which means there's a wide interest in this topic. Thank you for so comprehensively covering those two topics so well. We wish you well for your period of quarantine, and we'll look forward to discussing things with you as these pandemics sort of continue.
Yeah, thanks for the opportunity to speak with GPs. We see you as critical in both of these endeavors, and we look forward to working with you in the months to come.
Thank you, and I wish the audience a very good night.
Good night.
Thanks, Paul.
Thank you, everyone. Don't forget to fill in your survey. This will be emailed out in about half an hour to receive your CPD points, and hopefully we'll see you to another webinar soon. Good night, everyone.